Yeah, and with that, I am super excited to have Dr. Wambier here with us today as the speaker for our webinar. Dr. Wambier is Assistant Professor of Dermatology, Clinician Educator, and Medical Director of Clinical Trials at the Department of Dermatology at Brown University. Dr. Wambier has used these injectables many times. He's very experienced with them, and I'm very excited that Dr. Wambier will be speaking about mesotherapy today. And with that, I'd like to hand over to Dr. Wambier. Thank you.
Thank you, Lars, for the introduction. Let me share my screen here. It's a pleasure to be here, and I see many of my friends online. I see even Dr. Shapiro, Dr. David Orentrike, Dr. Kuhn here from Brown, and it's a pleasure to be here among friends. Dr. Capo from Florida, and well, I'll tell you that this procedure is one of my passions in dermatology. It's one of the things that I've been dedicating a lot of my practice. And I'd like to thank Chemistry RX for making this happen here in the US. When I first met Lars in New York in a NAF convention about some 3 years ago, I asked Lars for help to get those medications available for us to use on the office, because it was something that I felt the need here for practice in the United States. And there was only PRP, and I was doing microneedling on my patients without any medication. So I thank Chemistry RX. Today I'll talk about both methods, either the injections and also another method, which is the drug delivery through tattoo machines. I wouldn't advise anyone to start using the tattoo machines. Just start with the usual injections that you're used to, because tattoo machines, they can cause scars if you don't use them in the right form. It's not a tool that we're used to use in our practice. So let's go for the lecture. First of all, the disclosures. I'm a consultant for Chemistry RX, and this lecture had no inputs from Chemistry RX. It's just from my own mind, and we'll talk about basically about androgenetic alopecia. And this term was created by Dr. Norman Orentrike, the father of David, who is here. And I think that term is absolutely precise, because now we know the cause of this disease, which is just androgen expression, strong androgens that work on the follicle. They shrink the follicle, they miniaturize the follicle, make the follicle more superficial, and then the stem cells, they're closer to the surface of the epidermis and closer to sun damage without coverage. And it's absolutely essential to block the androgen activity to improve this disease. And I'll talk both about Dutasteride and Minoxidil, but I want to start with the message that Dutasteride is more important than Minoxidil to achieve better results. The first block is an overview, review literature about the intralesional use of Dutasteride and Minoxidil for AGA. And then I'll open to some questions about the literature. And then the second part is the most interesting part, which is just the procedure itself, how it's done, how to plan with the patient, and also have some demonstration videos, some before and afters to motivate you to start, and also some words about post-operative care, some specific issues for each patient, and then we'll open to a little discussion, questions and answers. Okay. Oh, the usual care for AGA is basically blocking the androgens, especially DHT, because suppressing the DHT doesn't cause feminization in men. While in women, we can block all the androgens with more ease. So we assume that DHT is the root cause of the disease. And I would say that currently the 5-alpha reductase inhibitor that is stronger, has more benefits for the patient is Dutasteride, and it can be used once a day or once every week, depending on the patient. It is more powerful than finasteride. Finasteride at 5 milligrams has more effects, but when we use finasteride, usually we use a lower dose. And I personally transition them from finasteride to Dutasteride as soon as I can. And spironolactone, basically for women, I would say that's the basic way of attacking the androgens. And we use minoxidil, which is a great hair stimulant. There's some restrictions in women because they can grow facial hair. So when we block the androgens together with minoxidil in women, we kind of prevent that. The oral form is there's more efficacy than the topical minoxidil, and it's also more comfortable for the patients. They don't have that gooey hair that they have with the topical. So my standard of care, when I can, is to use Dutasteride with oral minoxidil. But sometimes the patient, they don't respond well, or sometimes they have some adverse events from Dutasteride. And anyways, we can always advance if the patients have more severe disease, less vellus hair, less intermediary hair. We can always use the hair transplant in patients who have enough hair for density. And I would say that the frontiers nowadays is just better use of the topical anti-androgens with some special delivery systems and everything, and stronger anti-androgens for females, which there is plenty of evidence, but I'm sure that in the next years we'll start to use stronger anti-androgens. In Brazil, for a long time, dermatologists were using flutamide for females until it was prohibited in Brazil because of liver problems. And that raised a whole issue worldwide regarding flutamide liver toxicity. But we know that other anti-androgens, they are safer than flutamide, and they're even stronger anti-androgens nowadays. And well, procedures, microneedling, laser, radiofrequency, injectables. Here in the US, there's PRP. And now we have drugs. We can use some drugs that grow more hair. So the standard route, the topical application, it has this problem, which is the patient need to have frequent applications, let's say twice a day or once every day, and it can cause hair to stick. Some patients, they don't follow our recommendations because they don't like to use topicals, and overall they're less effective. And there's virtual dermal penetration. There's some transfollicular penetration. They're usually on lotions or alcohols that just evaporate really fast, and it's really hard to get medication to the dermis. And once the medication reaches the dermis, it is absorbed by the blood vessels and there's systemic action. Oral medication, there's more efficacy. The patients, they follow more our instructions and our prescription of oral medications. There's whole body distribution. There's low dermal concentration because it has to distribute all over the body and the fat and a lot of tissues, and it can cause more side effects. The main side effect that we are most concerned for minoxidil is edema, and for Dutasteride, sexual adverse events, erectile dysfunction in men, and of course, teratogenic effects in pregnant women. And the injections, they have more local action. We inject multiple bolus to the reticular dermis. It also goes to the sub-Q, even though we try to get a very superficial injection. There's high dermal concentration, and the drugs are slowly absorbed. And the idea of intralesional treatment is to minimize the systemic adverse events and try to have as less frequent injections as possible. And so there are some recent reviews about mesotherapy for hair loss, and there's already a lot of evidence, some 6 or now even more randomized controlled trials. And I personally don't like the term mesotherapy, not because I don't have anything against mesotherapy itself, but I think it's all intradermal injections or intralesional injections. So let's say, and we never hear a dermatologist saying that they will do mesotherapy of triamcinolone, right? They say, oh, we'll just do mesotherapy of triamcinolone to help your alopecia areata. We say intralesional triamcinolone. And the same is with other drugs. They're all intralesional or intradermal. Mesotherapy, there's this confusion, and also there's some, especially the older generation of dermatologists, they associate mesotherapy with the risk of infections, bad compounding, side effects. And I personally prefer to say either drug delivery or intralesional therapy. And when I review any article, I try to tell the author to change the term. Well, I started my journey on injectables for hair growth in 2009. I was in residency, last year of residency in Brazil, the senior residents, they're more free to use some therapy under the usual guidance of the attendees. And I started talking to my patients to mix minoxidil with their triamcinolone for alopecia areata, and I saw more results. The patients liked it more, and I started using very often. And after residency, I started to use the combination of very dilute triamcinolone, like 1 milligram per cc, with minoxidil for AGA, and I had some interesting results, better than just the usual care. And I always try to use that in my patients. I'll show you one example. This is one of my first patients that had a drastic improvement. She had AGA for many, many years, 2 decades. She had photo aging on the scalp, and she came with a bandana, and she said, you know, I'm here because I want some better photo protection for my scalp. I don't like to use hats. I use the bandanas. I still burn my scalp when I'm out, and I try to use sunscreen. And and when I looked and I saw she had a lot of vellus hair, which is hard to see on the picture. And then I said, hey, do you want to try some injections? Triamcinolone, maybe you also have some autoimmune disease or some inflammation in your scalp. Looks like AGA. Let's start also systemic anti-androgen and all the usual care. And she was a little reluctant. So I said, oh, so can I start with the frontal part or just inject on a part of your scalp and also this side that looks worse? And she agreed. And after 1 month, she had some hair. She was a little excited. Said, yeah, I'll try again. And on this session, I'm trying to inject more on the back. And I also injected on the frontal part. And she came after 1 month looking like this. And she was very mad at me because she was waiting on the waiting room for 1 hour. But I said, oh my God, did you see the difference on your scalp? And she said, yeah, I felt some growth here on the front. And I showed her a picture of before, and she was like, oh my goodness, yeah, let's continue the therapy. So after 1 more session, she was looking like this. And yeah, that's basically in about 4 months of therapy. And she continued following with other dermatologists, and she seems to still be happy with good hair. The major change in the injectables was the 5-alpha reductase inhibitors. In 2011, I started to use finasteride. It became available, compounded, and I started to mix with minoxidil, even though the compounding pharmacy didn't want me to mix. They saw that there was less stability on the formula. They couldn't sell as the double agents, but I was mixing in my own syringes, sometimes also with triamcinolone, and well, yeah, that improved the results, especially in men. And 2015, Dutasteride became available, and since then I basically stopped using triamcinolone for AGA. I only use 5-alpha reductase inhibitors and minoxidil because I didn't see any difference of adding triamcinolone. So some results of minoxidil with dutasteride. Here is after 1 month of a single session, same spot on the scalp. There's another patient with injections, 1 session, 2 sessions. He was very excited about those results. And when I moved to using the tattoo machine, he didn't want to go to the tattoo machine. He tried once. He preferred the injections because he saw a lot of results in the beginning. And anyways, so nowadays I personally use for AGA basically tattoo machines to deliver drugs because they seem to be more deliver more results because we deliver the drugs more to the superficial dermis where the vellus hair are. And also there's the advantage of associating microneedling with the growth factors that are released, the healing, the injury and healing from microneedling with the medications. They're highly concentrated in the upper dermis. Sometimes I use intralesional. Still, I feel that for alopecia areata, intralesional is much better than tattooing, maybe because of the lymphatics, some lymphocytes that are deeper. And the level of injections, we can only inject with a syringe around 2 millimeters, 5 millimeters deep. We cannot get the injection with pressure to the very surface, papillary dermis. It's almost impossible. There's a lot of spray on the through the follicles if you do it. And sometimes I inject with triamcinolone. Still, this is a case of a cutis versus gyrata. The patient had very thick hair with hair loss, or maybe just the distension of the scalp. And I use, to shrink skin, I use higher concentrations of triamcinolone, like 10 milligrams. And why not just mix with minoxidil to have more hair growth? And patients like, this is after, I think, 2 sessions here. The Dutasteride. So now I'll go through the review of injections of Dutasteride and also the side effects. It is approved under the FDA for BPH. It's used all over the world off-label, just like we use spironolactone off-label. And it seems that some countries, Japan and South Korea, they have Dutasteride on label for AGA. And they had the studies that were published basically to get the label. And well, this is one study of many patients taking it for a long time, open label, and they saw that about 78% of patients improved with different time. They were all very young patients, around 18 to 41. And the reported incidence of erectile dysfunction was 1%, and reduced libido 1.3, gynecomastia very low, almost 0%. It's a very safe medication overall. There was another trial that looked specifically for sexual function and was asking every single patient a questionnaire, and they saw that during the double-blinded part of the trial, about 15% of patients had some sexual adverse events, which were mostly reduction of ejaculate volume, but a lot of patients complained of ED, while 8% on the placebo group had the same. But overall, 0% of patients decided to stop the medication during the trial because they saw that the effects were getting better over time. So the patients who felt erectile dysfunction, after 2 or 3 weeks, they were feeling better, but they reported that. And on the open label extension, which was a longer period, they only saw around 5% of patients having sexual adverse events. So in general, they are expected, reversible, but that's also an issue that generates discussion with the patients. And the idea of microinjections of dutasteride to minimize the exposure, maybe some patients they felt some side effects, they want to change the therapy. The first trial that happened was in 2009. It was a pilot study with 34 patients, and they found compared saline injections with dutasteride. The patients were blinded. The physician was not, and they saw 92% improvement of hair growth on the pictures, and the patients basically they all agreed that there was improvement. While on the placebo arm, the patients they reported by looking at the pictures, only 7% of the patients had some improvement, while the clinicians they saw about 30% of improvement on the placebo arm, which is probably from the injuries of the needles, something, because it's not expected to improve AGA spontaneously, right? And the treatment was just very difficult to do on the usual practice, like weekly sessions, and then followed by one session every 2 weeks. And the results were only in the first 3 months, which is very too fast to get more consistent results. So it's probably higher if they went long term. And after 4 years, there were some two good trials. One with 90 patients, which they compared 2 doses of injectable dutasteride, 0.05 and 0.005, and which is basically a phase 2 trial to check for adverse events, check some things on the blood, even though only the patient was blinded, the physician was not. And they found much better results with the higher dose of dutasteride, which is expected. And they injected 2 cc's of that concentration weekly for 6 weeks, and then monthly. And the treatment was also very short. And they followed for 5 months. And as a monotherapy, they saw 80% of improvement with a higher concentration, 30% with a very low concentration, and 20% on the placebo arm. And they saw that on the higher dose, there was reduction on serum DHT, which we don't know if it means anything, but it seems to block overall systemic DHT. And if you think of the dose, it is basically two capsules at once every week for 6 weeks. So it's absolutely expected to have lowering of DHT and systemic action with that dose of dutasteride. Well, there was a large study on females that they were on birth control, of course, or after menopause, and with the same dose of the first studies, 0.005, and they saw interesting results in females too as a monotherapy. And then after 4 years, there were some other case studies, case reports. There was one small series of 1 female, 5 men with a very lower concentration of dutasteride. And every 3 months, which is more something that we can do in the clinic, and they saw huge benefit. 100% of patients had improvement, but they didn't have any placebo control. And they measured androgens, and they didn't find any change in androgen levels, just like the 0.005%, which didn't change any androgen levels. And there was another case series that also saw good improvement. And with 6 months, only 2 sessions, that was okay. Probably with more sessions, they would get more benefit. And about the same time, there were some other case reports. There was a case report with only 5 men with 100% improvement. I'll show some pictures, which are really amazing, of this one later. And it was basically every 3 months, 1 session. They followed for 1 year. It was a retrospective case series, and everybody had standard of care. So basically the patients were getting those injections, or were the ones that didn't want to take finasteride or dutasteride, or didn't respond for a long time, then they stopped. But everybody was with standard of care, and then there was 100% of patients getting results. I also had a series of cases presented in a World Congress of Hair Research in Barcelona, a poster in the AAD, also a poster in the SID about this series of cases. We'll get this published soon, of 15 cases, and I'll show the pictures later. And my combination was 0.005% minoxidil or dutasteride combined with minoxidil. And all the patients were with standard of care. They were taking their oral 5-alpha reductase inhibitors for at least 6 months, and topical minoxidil, everything, and everybody improved. I'll show some pictures to show that not everybody improved to the extent that we want. And the treatment was every month for the series. Usually I start with every month, and then I extend to 2 months. And it's only with about 4 months of follow-up. And I detected that with some damaged scalp, there was less response, more chronic cases, less vellus hair. And now in 2022, there's 2 articles, which were really amazing. Both were retrospective, one with 105 men. One arm had oral minoxidil only, and the other cohort had oral minoxidil with intralesional dutasteride. And they didn't say mesotherapy on that article. So they found that both work, both improve. About some 91% of cases followed for, let's say, some 4 months. But the patients who had intralesional dutasteride, they improved much more on the vertex in the back than the patients were only on oral minoxidil. And yeah, they reported no sexual adverse events in both groups, and they questioned the patients about that, which is very interesting. Large series of cases, and there was recently a new one, series of cases with many patients, hundreds of patients. I think this series was from Mexico, using the same concentration, 0.001, and they found some patients were on monotherapy of the injections, which were a few patients, only 86 patients of the total, and they could measure results on those patients too. Here's the monotherapy. 57% of men had improvement, and 80% of women. And anyways, so here's some pictures of from literature of the improvement with intralesional dutasteride. This is one of the best cases I've ever seen. This patient, he didn't have any treatment before. They started him on a injectable dutasteride every 3 months, and also topical minoxidil, and such an amazing result. One case from the female cohort of dutasteride with good results. This is the most recent one, and no sexual dysfunction, and they saw better results on the vertex. And if you see the vertex results here, 27.7% of the patients who received intralesional dutasteride had marked improvement on the vertex, versus only 3% on the oral dutasteride. Well, let's talk about minoxidil. Minoxidil is actually a prodrug. It's not active until it becomes, there's this sulfatransferase enzyme that binds a sulfur group to minoxidil and makes it more soluble to the areas that it is intended to work. It's sulfatransferase for phenolic compounds. And it's very important to understand that it's only a prodrug, because some patients, they don't respond to minoxidil. So we can try to make it work by binding more sulfur. And the activity of this enzyme, sulfatransferase, was shown to be completely related to the action of topical minoxidil. And we can enhance this enzyme by using tretinoin, which increases the follicular enzymes, and also with microneedling. Basically, anything that can irritate the scalp can make the sulfatransferase work more. And the way of inhibiting this enzyme or reducing the effectiveness of minoxidil is to use anti-inflammatory drugs. And aspirin, particularly, there's a binding site for aspirin that blocks the sulfatransferase. So basically, if the patient's taking low dose aspirin, I don't even go to minoxidil unless I try to stimulate with something else, the scalp. And about injectable minoxidil, the first reported article here was with 2% minoxidil. They were comparing topical 2% versus injections with this mesogun, which is an easy way of injecting, preserves the thumb. I personally don't like machines. I prefer to inject with the thumb because I can feel if I'm on a blood vessel, or I'll say the resistance of the dermis. And they got some good results, and they saw that the injectable had 80% improvement versus 56% of the topical. And the intradermal injections, there was the study done in Brazil with 0.5% minoxidil, which is what I'm more used to injecting. And this was a master science thesis from Barbara Utzel. She was mentored by my friend Iselda Costa. She used to be the president of the Brazilian Society of Dermatology. She's a very serious researcher. And one day after I gave a lecture of phenol peels, I had a talk with her. She said, "Oh, I'm mentoring Barbara, and I don't think that will work." So she was very, skeptical about mesotherapy, especially with minoxidil. But here are their findings. They found reduction of vellus hair on the minoxidil group, while on the placebo or the saline, they found less terminal hair, more vellus hair using placebo, and the percentage of anagen hairs was also improved. And what I consider the most important thing, which is the self-evaluation of pictures by the patients. They know what they want to look like. And on the patient's assessment, almost 70% improved with the minoxidil series of injections. They were doing weekly injections of minoxidil. And there was loss of volume on 25% of patients who use saline 0% on minoxidil. And here's one case of the placebo group that lost volume of hair, while the minoxidil, everybody grew hair. Okay, now let's open to some questions. Let me just.
Yeah, so everyone, if you have any questions, you can type them in the chat, and then I will summarize them to Dr. Wambier. You have a button in the webinar, and you can use it to type in your questions if you would like.
Is there questions about the review of literature or anything? If you don't have any questions, then I can move to the practical part.
I have one question, actually a couple of questions coming in now. One question, if the dutasteride is a solution or a suspension. The dutasteride is a solution, just as the minoxidil. Then one question, Carlos, for you, any injection site effects, granulomas that you have observed?
Yes, I'll show on the practical part. Well, there's a granuloma. One thing that I'm very concerned is about silicone oil on the syringes. So basically, all the syringes that we generally use, they are lubricated with silicone oil. And the more you use them, the more you inject silicone oil to the scalp. Even though we know silicone oil is absolutely safe, some patients, they can develop more granulomas. And also silicone oil interacts with the fat and causes fibrosis on the fat. So it can cause this retraction of scalp, especially if you inject too deep. So it's very important not to inject on the fat, try to go only in the dermis and with minimal volume. I'll mention that in the future. And there's some side effects in literature about edema on the face and also in the forehead that usually resolved with prednisone. And what about females of childbearing potential for minoxidil? I think that's an interesting question. So I don't think there's any, let's say, specific recommendation of patients to be on birth control to receive those injections, just like we prescribe oral minoxidil. But then, let's say, as soon as the patient knows that they're pregnant, or if they want to do a pregnancy test, if they don't have, they're not sure if they're pregnant or not, that's certainly advisable, because minoxidil can interfere with the fetus, even though it's not an X medication like dutasteride. And specifically for women, dutasteride has a very long half-life. So it takes 6 months for the body to clear from dutasteride. So I would not use dutasteride for females that can get pregnant.
Carlos, one question on the maintenance. How do you maintain the results either with injections or with oral drugs?
Nowadays, with oral minoxidil, I think it helps. After we achieve the results and the patient, they don't want to continue the injectables, we can try to maintain the results. On my practice, I could not maintain the results with the usual care. So usually around 3 months, 4 months after the last injection, the patients were noticing reduction of volume and they wanted to get another injection, even with oral minoxidil every single day. And back in the day, I didn't use oral minoxidil. I think that can certainly help to maintain the results. Any other questions? Let me see.
Do you have any experience with the scarring alopecia, CCCA, for instance, and treatment with injectables?
Yeah. Well, for FFA, I use tattoo machines with triamcinolone and also with dutasteride, minoxidil, anything. The reason why I use it on FFA is that I noticed that when I inject triamcinolone, there's a lot of atrophy. the patients have extreme high incidence of atrophy, even with lower dose of triamcinolone, especially on the eyebrows. So with the tattoo machines that minimize, I never seen a single case of atrophy with a tattoo machine. It delivers too superficial in the dermis. And well, yes, I use them. And you can also inject. The benefit of using Dutasteride is that it doesn't cause any atrophy, just like on I consider standard of care for FFA to use oral Dutasteride, and why not micro inject to achieve higher concentrations? Anything else?
Yeah, one question on your ideal treatment interval. I think you're gonna talk about this in the next part of the talk, correct?
And okay, so I'll move forward to the other part, which is the practical part. There's some videos. I noticed that my screen is a little slow. Sorry about that. The connection is not that great. But I hope you can see some videos. Okay. Can I share my screen?